Thank you, Dr. Alka. Come, I'll just make a comment. Because we are running short of time, I will...
Thank you.
Thank you so much for that kind introduction. Good afternoon, everyone. At the outset, I would like to thank Sanjay and Neeta, of course, and Team IDEC for this great opportunity. It's always a pleasure to be in this meeting because there is a lot of science and a lot of, new discussions that happen. And it's always good learning in IDEC. So, the drawback is that every time, since Neeta is involved in making the program, she always gives me something to do with obesity. And I'm not considered a diabetes person here. So today I'm going to speak on the concept of ABCD, clinical evaluation for disease staging. This is not exactly a new concept, but very recent concept. And in this presentation, I don't have any disclosure. What I plan to do in this presentation is to first build up the concept of what is exactly ABCD, why we need to use ABCD as a new terminology in the field of obesity, and then of course the staging that finally I will talk about the staging that is based on this concept. So I don't have any disclosure. What is ABCD? ABCD is basically adiposity-based chronic disease. It is a new term to use in place of obesity, or a new definition which is likely to replace obesity as a definition. Now we know obesity is a major healthcare challenge, and we know that there is this sharp increase in prevalence all across North America. India is no way behind. If you look at the top graph, it is 2006 to 1990, and between 1990 and 2016, the prevalence of obesity has increased by almost 3 times, and we have a significant number of obese individuals in India. And this graph also shows you the age and sex-specific prevalence of obesity in India. Now, we recently had the NHFS 5, which is the National Family Health Survey, and this again looked at the increase in prevalence between 2016 and 2020. That is National Family Health Survey 4 and 5. And in 4 years' time, actually, there is almost 4% increase in prevalence in obesity, both in men and women. It increased from 21% to 24% in women, and from 19 to 23% in men. And the number of thin individuals is decreasing. Another important thing is, this time they also looked at the first time any obesity survey looked at the waist hip circumference. And to everybody's surprise, almost 50% of men and 57% of women have a waist hip ratio which is abnormal. They have an increased waist circumference. And this is a big challenge. Now, we know obesity is defined as abnormal or excessive fat accumulation that may impair health. So the definition does not define weight. It is abnormal or excessive fat that is associated with poor health. But the definition does not convey, the word obesity doesn't convey it. It is a complex subject. The definition of excess of fat is also not clear. It is a continuous trait, not marked by clear division into normal and abnormal. It is very difficult to measure body fat unless we are doing a MRI or, say, advanced DEXA in every individual. We can't measure body fat. And then, because we can't define body fat, we are using surrogate measures to define obesity based on body weight. And the commonly used parameters that are used are body mass index, waist circumference, and waist hip ratio. And waist circumference is one of the defining cutoffs for defining central obesity, and waist circumference, waist hip ratio also. Now, there are studies which have clearly shown that there is a strong correlation between body mass index and total body percent fat, both in men and women. Then why can't we use body mass index as a parameter or definition for obesity, and why do we need a new term? So basically, there are multiple objections to use of term obesity or body mass index as a parameter of obesity. And this is because there are varying cutoffs for different ethnicities. Western people have a different cutoff for body mass index. We have a different one. The effect of increased or decreased muscle mass on body mass index is also, something to be addressed. And there are independent cardiometabolic risk fact that is associated with waist circumference, even independent of body mass index. So it doesn't convey the complete risk. So obesity basically is considered as an imprecise term. It is defined on the basis of BMI cutoff, not based on the adiposity or adipose tissue or fat mass, and does not convey health risk of obesity since the definition is based on an anthropometric measurement. It is not considered as an actionable term or definition as its relationship to individual health is also obscure. So you say BMI of 30, it doesn't convey what kind of health risk is there. So it conveys very little about the condition which is associated with increased fat mass in the body and the health risk associated with it. And it also carries a great deal of stigmatization, negativity with this term. In fact, the stigmatization is so much that there was a joint international consensus statement on ending stigma associated with obesity. This obesity stigma, kind of denigrates the people with obesity. It puts the blame of obesity on individual itself, that they are obese because they are lazy, they are eating more, and so on. Again, if you look at BMI at different ages, with age, the percent body fat is changing, but the BMI may be same. And there is loss of muscle mass with aging, there is increased fat mass, but the BMI remains same. There are different, relationship with different risk parameters with BMI also. So it's a metric of bigness or adiposity amount or the body weight amount, not exactly adiposity amount also. And it does not also explain the obesity paradox. We have studies which have shown that people who have coronary artery disease or congestive heart failure, if they are obese, the risk of mortality is lower. So it doesn't explain obesity paradox. It doesn't explain the metabolically healthy obese phenomena. And it was not a component of the major epidemiological studies like Framingham or pooled cohort studies for CVD risk scores. So what has happened in the recent time is that ACE, AAC, and ACE, American College of Endocrinology, have created a chronic care model with advanced diagnostic framework and also clinical practice guidelines, which help in clinical practice algorithm for comprehensive management of obesity, which are offering you a comprehensive system of obesity management. And this is called ABCD or adiposity based chronic disease. It is not solely based on the body mass index as in previous models, and it emphasizes on the complication centric approach that primarily defines the therapeutic decision making based on the different parameters. So ABCD is the new diagnostic term for obesity that explicitly identifies this as a chronic disease, which is now worldwide done, and alludes to a precise pathophysiological basis and avoids the stigma and confusion related to differential use of multiple meanings of the term obesity. And the first time there was a position statement from ACE and AAC in 2006 led by Jeffrey Mechanic, who was the president that time. And this basically has 4 key elements imbibed into this definition. First is the positioning of lifestyle medicine in the promotion of overall health, not just the initial first algorithmic step, but it is the central to management of obesity. Second, it has standardized protocols for comprehensively and durably address the weight loss and management of adiposity-related complications. Third, it also helps in giving you an approach to patient care through contextualization, that is, who needs primordial prevention, who needs primary prevention, who needs secondary prevention. And it is also giving you a system of developing evidence-based strategies for successful implementation, monitoring, and optimization of patient care who are having adiposity and its associated risk or complication. So term adiposity directly refers to adipocytes and adipose tissue, not body weight. It incorporates the impact on health that can relate to quality, distribution and function of adipose tissue. All these are important. It is not just the adipose tissue, it is the quantity, it is the quality and the distribution. The quantity of fat mass can correlate with the certain adverse clinical endpoints and adiposity-based complications, but is inadequately reflected in the term BMI. BMI just gives you body mass index. It doesn't give you the amount of adipose tissue or dysfunction. Then distribution of body fat is also very important. We all know that central fat distribution or more of visceral fat is associated with insulin resistance, increased risk of diabetes, while if you have more of gluteofemoral fat, it is protective against cardiovascular risk and risk for insulin resistance. Then the functional attributes of fat are also governed by different factors, and the adipocyte secretome, which includes the various factors or cytokines secreted by adipose tissue, not only they are important, it is also the cytokines, hormonal factors and other hormones which control this adipocyte secretome are also equally important. And once there is dysregulated secretion of all these factors, it is going through bloodstream and it is going to affect the multiple organs, leading to the health risk associated with obesity. So when this abnormal function of adipose tissue happens, this ultimately translates into disturbed physiology and development of symptoms, which define a disease. And if disease persists for more than 3 months, it is called chronic disease. And once there is a chronic disease, body gets into adaptive and maladaptive processes, ultimately achieving a steady state and leading to ongoing development of complications. So, for example, you have a increase in amount of fat because you have genetic predisposition, environmental circumstances, less physical activity, and so on. Once there is increased body fat, the fat mass, it leads to malfunction of the adipose tissue. This is further influenced by your physical environment as well as the cultural environment, ultimately leading to adiposity-based complications and different disease stages. And the concept is that ABCD should be used for medical diagnostic purposes and precise reference to chronic disease state with related disease stages, which is divested from the stigmata or ambiguity associated with the word obesity in general public sphere. So obesity is just not body mass or the body weight or the large size of body. And now in 2019, the European Association for Study of Obesity also took this up. And this is a position statement which looked at ABCD as the diagnostic term. And it recognized that scientific societies both in Europe and North America now recognize obesity as a frequent, serious, complex, relapsing and chronic disease that represents a major public healthcare problem. In addition, the term obesity is fraught with stigma and negativity regarding the personal character of the patients with disease. And now worldwide, the word obese patient is considered as an unparliamentary word. You have to call them people with obesity or person with obesity. You don't call them obese patients. Similarly, you don't call them diabetic patients. So obesity complications are determined by two main pathophysiological processes: the physical forces, that is the fat mass, and the dysfunctional fat or the sick fat, which are embedded in the cultural and physical context, leading to the specific ABCD stages that are defined based on this concept. And BMI as a unique measurement of obesity does not reflect the whole complexity of disease and should not be considered as the basic definition of obesity. Yet BMI is simple, easy and inexpensive way of identifying the extra fat mass in body. It is still being retained, but you have to look at the stages of disease based on the ABCD algorithm. The limitations I have already discussed about BMI. So ABCD conceptual framework of obesity incorporates the characteristics of adiposity, including the total amount, distribution, as well as the dysfunction of adipose tissue. It also takes care of the physical, which is the man-made or human environment, which includes food availability, transportation, and so on. It also includes, it takes into consideration the cultural, which includes the socio-political, economic aspects, various customs and rituals that we have been following over time. And together with the clinical burden derived from the impact of dysfunctional fat over time, which leads to development of complications and gender-specific disease stages. So you have adipose tissue which is increased. Now this is increased because of multiple reasons. You have genetic predisposition, you have epigenetic factors, you have decreased physical activity, and so on. Once there is increase in adipose tissue, there is dysfunction, and first thing is the distribution. So there is a tendency to accumulate more of central fat versus peripheral fat. Once there is more central fat, there is dysfunction of the fat. And if there is, dysfunction of the fat, you get sick fat and development of insulin resistance and other diseases. If you just have more fat mass without dysfunction, you get more of the mechanical complications of obesity. And all this is influenced by your man-made environment, which is the man-made environment, as well as the socio-cultural factors, and together they combined, they lead to development of the so-called adiposity-based chronic disease with complication which are gender-specific given in the disease staging system. So, and based on this, they also define the levels of prevention that are required for different stages. So genetics, environment, epigenetics all lead to development of primary disease risk factors, and people who are at higher risk go on to development of ABCD or obesity. So-called obesity is ABCD now. Now these individuals can be insulin sensitive if they just have fat mass without dysfunction of fat, or they have insulin resistance where the fat is dysfunctional with the release of more cytokines, free fatty acids, and so on. These people will develop components of metabolic syndrome, and down the line they will develop diabetes, atherosclerotic cardiovascular disease, hypertension, dyslipidemia, NASH, NAFLD, and so on. While on the other hand, people who remain insulin sensitive, they develop more of mechanical issues like osteoarthritis, obstructive sleep apnea, and so on. Now, early stages, before the development of obesity, you have to look at primordial prevention in people who are exposed to the obesogenic environment. So people who, now everybody, we are all exposed to obesogenic environment. Let us assume that. So we all need primordial prevention. Now, people who are at higher risk of developing obesity, and they are also exposed to this environment, who have risk factors, actually they should be on primary prevention for obesity. And once we develop obesity, you need the secondary prevention of obesity now to prevent the complications of obesity. And once people have got complications of obesity like coronary artery disease, diabetes, and so on, you actually need to put in tertiary prevention measures. So this slide actually gives you, all kinds of measures that are thought of in primordial prevention or primary prevention. Secondary prevention, you have to advise them weight loss to the tune of 10%. If you have complications in place, maybe you need to give them more weight loss. So this is the algorithm for staging which is proposed. And actually it is a busy slide, but you will see here that not everybody with BMI of more than 30 is considered a bad patient. So people who have BMI less than 25 or 23, depending on ethnicity, actually all are cases for primordial prevention or the primary prevention if they are having risk factors. People who have BMI more than 25 or more than 20 or more than 30 or more than 25, they can be classified as stage 0 of obesity, and you have to see whether they have already some complications, which is metabolic syndrome, prediabetes, diabetes, dyslipidemia, and so on. And if any of these is present, then you define them again on the basis of presence or absence of disease. So stage 0 is when there is no complication, and you have to put them in secondary prevention mode. And if you have stage 1, When it is mild to moderate complications, and you have to look at the tertiary prevention. Stage 2, which is more than one complications, again you go to tertiary prevention then. And these are the components that you have to issue in management of these obese patients. So irrespective of the BMI, for the same BMI, you may be having different approaches for different people. People who do not have established complications are at a high risk, have a different approach. People who do not have any risk have a different approach. And people who have complications have a different approach. So this is the basic concept and of ABCD and ABCD based staging of disease and how you go about managing this disease. So with this, I conclude my presentation. I would also like to invite you all to the RSSDI National Conference, which is happening on 6th to 9th of October, 2022 in Chennai. I would also like to invite you for the ACCD program that I do in Delhi every year. Thank you so much.